About trachs today. Trachs are the definition of is a surgical procedure to make an opening into the trachea, right? Reasons for trachs, is blocked upper airway related to trauma, allergic reaction, tumor, smoke or steam inhalation, chemical burn, surgical removal of the larynx with a permanent stoma, weakened muscles related to any kind of long-term neuromuscular disease issues with our patient, long-term coma, paralysis, long-term endotracheal tube placement. So a lot of these patients you guys may see in the not in the near future, hopefully not, but you will see patients that have been in a nursing care facility or somebody that's had a long disease process that has caused them to need a trach for some kind of airway management. We use our trachs not only for airway management, but we use it for secretions. So that could be the other reason why we have to have a trach in a patient, all right? Patient isn't able to cough up their own secretions. We have to go down and suction them out. And as I say, sometimes we need it for airway availability because we have to put a patient on a ventilator, or we need to, we've had a patient that's had some kind of surgical intervention, such as laryngectomy, and they need some kind of an airway, right? And different types of trachs that we have. This one happens to be a cuffed trach, which stands for there's a little balloon on the proximal end of the trach to help maintain placement. And it says only, I should underline that, help. It does not keep that trach in place, okay, you guys? So it's really important for you to remember that. And to assist in blocking block secretions from the upper airway and for use in a ventilator. Okay, so when we're talking about a patient with a ventilator, as we're forcing that air into the patient's lungs, if we don't have this trach with the balloon on the end of it, the air is going to come up around the trach. Okay, if we have a patient that is at high risk for aspiration or frequently aspirating, this can help block those secretions from the upper airway getting down into the trachea, right? So you'll see that there's the balloon on the end of it, and what it looks like on the outside is it looks like this little pilot balloon on the outside. We can see that it's inflated because we can't see what's going on inside our patient, right? Okay, and I say that we want this to help keep the trach in place. The thing that's keeping the trach in place are these ties. Okay, the balloon is not meant to keep the trach inside the trachea there, because if we put too much pressure on this, it will cause erosion to the side walls of the trachea, and our patient can develop a fistula. All right. The other one is a cuffless trach. So a patient that's non-ventilated, that has minimal risk for aspiration, we can put this in our patient. As you can see, the difference is that air goes in, it comes out of both the trach, and it can go up between the vocal cords if they still have vocal cords. Okay, so it allows a little bit better ventilation. This is going to be for somebody that we just need to primarily clean secretions out on. All right, some of the complications that can happen to our patient is we can get abnormal tissue granulation in the airways, irritation of the windpipe, inside lining from the tubing rubbing against the lining surface. So that can be if we do not have this thing inflated enough, or if we do not have the trach ties secure enough. This can move in and out. Okay, so we don't want to see a lot of play of this moving in and out of the patient. All right, this shouldn't move in and out of them very easily. We can get blockage of secretions, which can actually completely occlude our airway. All right, so we need to make sure that we're humidifying the patient's air that's going into them. You think about it, we're blocking the airway, we're blocking any moisture because we're bypassing the nose. So we need to give them artificial mucus or fluid down there to allow the mucus to be of a consistency that we can suction out of our patient, right? And we can develop infections, and we can have our patient have a failure of the trach to close after it's removed. right? At the bedside, we want to have a bag valve mask. We want to have a trach that's the same size and one size smaller, a 10 cc syringe, and we want to have a suction kit. All right? The reason we want to have that trach same size and one size smaller is if that trach does come out and we need to put it back in an emergency, we want to be able to have something there that the physician can go ahead and put it back in with. Okay? So in that first 24 to 48 hours, if that trach comes out, we're probably more than likely not going to be able to get the same size trach back in the patient. If we have a size 8, we're not likely going to be able to put it back in because there's so much swelling and stuff with the initial trach insertion. So you see that I put it in red here. If the trach falls out, do not attempt to put it back in unless you're trained. Okay? You can cause a lot more damage to your patient by putting that trach back in there if you're not trained on how to do it. So unless that patient's had that trach in for 2 or 3 years, there's going to be really nice granulation of tissue around the stoma site, and you can easily put it in. Most of the patients that you're going to be seeing in acute care have not had trachs in for long periods of time. Rarely will you see a patient come from a skilled facility that's had one in. But in acute care, you guys have resources available to you. You have emergency room physicians, you have rapid response, and you have RT available for you to help assist you. So if my trach does come out and I still have a connection between my larynx and my trachea, I want to cover the trach site and I want to bag valve mask my patient, okay? If I've had a patient that has had some kind of a surgical intervention and has had their larynx removed, then I'm going to bag valve mask directly over their stoma, okay? Or if I have somebody that has a severe facial trauma, right? Need for suctioning. When do we decide? How do we do it? We always assess our patient before suctioning. Okay. Does the patient have increased work of breathing? What's the change in the respiratory status? Is it more labored? Is it increased? Are SATs decreasing? Do they have copious secretions? Copious secretions are mainly going to be for their patient that we have here set up in bed 4 and bed 5 that are not to a ventilator. Okay, because they don't have any pressure of ventilation forcing down those secretions, we will have our patient, when they cough real strongly, they can a lot of times bring those secretions up by themselves. Okay, is the patient having unsuccessful attempts to clear the secretions? A lot of times our patients are awake enough that we can have them try to cough and then we can easily suction them out. And as I say, suction always involves assessment, oxygenation management, and the use of correct use of suction pressure, proper size of suction catheter, and distance down the trach. When I talk about distance down the trach is we only need to go 1/2 to 1 centimeter past the end of the trach is all we need to do. Okay, we don't need to go way down into the chest. How we do nasotracheal suction, and all we're trying to do is just promote a cough from our patient. Okay, and all we're doing is just promoting a cough, and then we are going through and suctioning. Now, you guys remember that when we talk about suctioning, we always want to only suction on the way out. All right, we don't want to apply suction when we're going in because we're sucking out that patient's oxygen. All right, when we are applying suction, we're taking out that oxygen, so we want to only do it for the shortest amount of time. Okay, it's not something that we put it in as we're going in, and as we're going out, the patient's saturations will significantly drop. Before we suction, we're going to hyperoxygenate our patient if they're on a ventilator. Okay, so if they're on a ventilator, you're going to have a little button on there that says 100% O2 suction. It will increase their It will increase their oxygen from the level their maintenance is at. Say they're at 40%, it will increase them to 100% for 2 minutes. If I have a patient that is not on a ventilator and we're going to come to the bedside, the only time I would bag a patient is if their SATs are extremely low and my patient is in really severe respiratory distress. Otherwise, if you can think about what you're doing, if you bag valve mask a patient, as you see in some of your videos, what you're going to do is you're going to force those secretions right back down into the lungs. Okay, so if the patient's got a strong enough cough and can get those secretions out, I'm going to try suctioning them first to get out what I can. And if my sats are still low, then I'm going to bag valve mask my patient. Okay. We can use the obturator that we're going to have at the bedside. What the obturator is it's an introducer that's going to be the same distance as my trach. Okay, so it'll give you some idea of how long this trach is that's in the patient. And as I say, we only want to go 1/2 to 1 centimeter past the end of the tube. So this being in my patient, I really have kind of a hard time guesstimating how far it is. Okay. We want to suction for no more than 10 to 15 seconds, and we only suction when we are pulling the catheter out. Cleaning the trach should be done per hospital policy and PRN. Usually that means once a shift, and that also means changing the inner cannula at the same time. Trach ties should be secured at all times, either with Velcro or with some kind of twill tape. Okay, so at all times it should be having this. Even when I'm changing trach ties, I want to have these attached. All right. If I have to do it with being able to remove them, I want to have 2 people in there with me. Otherwise, you can do this by yourself. And that's it, guys. We're going to go to the bedside.
I have a question.
Okay, so questions first, and then we'll go to the bedside.
When you're talking about the purpose of the cuff on a ventilated patient, you said something about preventing the oxygen from going.
So from the air going back up around the trach. So this balloon here completely occludes the trachea, so air can only go in and out via here.
Okay.
All right? If I have this balloon deflated, then as I force the air in, Allie, some of it can come out and around the trach. Okay? And you guys, when you see the trachs a little bit more in person, you'll be able to understand that when you see it inflated and deflated.
With the cuffless one, can they speak?
Yes, they can. Yes.
So if that cuff is a little bit deflated, they'll be able to speak as well?
If it's completely deflated. So the patient gets, the trach is determined by the size of the patient. This is a number 10 trach. It's a huge trach. So if I have a really small person and I were to put this in my patient, then I would completely occlude their trachea. We want a little bit of play in there so that this does not hit the side walls of the trach. Okay, there's going to be a little tiny bit of a gap. So then when we inflate it, this is barely hitting the side walls and it's occluding it, so the air only goes in and out through the trach. Anybody else? Yeah.
I forgot.
Go ahead.
It's okay. It's okay.
I forgot about hyperoxygenation. So you give him 100% for how long, and how do you monitor?
On the ventilator, there will be a little button on there that will say 100% O2, and it will automatically shut off for 2 minutes, after 2 minutes. So on your ventilators, it will always have a button on there that will say for suctioning. Kat, you had a question.
I'm a little confused about using the BVM.
Uh-huh.
When would you use that versus just oxygenating them with the ventilator?
When I don't have a patient that, like this patient over here, that does not have any kind of ventilator, they're breathing only.
They don't always have a ventilator. I get
They
it.
don't always have a ventilator.
Okay.
So if I have somebody that's not on a ventilator, I'm going to use the bag valve mask.
Okay.
Okay.
And then it forces the secretions down, and that's not a good thing.
Correct. It's not a good thing because we're going to, so if we force that air into the patient, we're forcing those secretions back down into the lungs and stuff, and that's counterproductive of what we're trying to do.
Oh, okay. I was just confused by the
That's
word.
okay.
So now I get it, because it's saying if you
When we need to suction a patient, it's counterintuitive because we're forcing those secretions back down. Now, if we're trying to ventilate a patient because we have low saturations, yes, we would use a bag valve mask just to get the oxygen into their system.
Yeah, easy enough. I think the wording
Got-
is confusing.
It's
I
okay.
get it now.
No, you're not the only one. It took me a while too. Wait a second, why? Okay, you guys okay? We're going to come to the bedside. I'm going to show you guys how to suction real quick. Then we're going to be done. Oh, let me get a suction kit. Okay, so when you come to the bedside, you guys are going to need a suction kit. And we're going to do this real quick. Okay. Okay, so I've having a fairly awake alert patient here that's able to call me and tell me that he's having respiratory distress, or I can hear I walk by his room and I hear his O2 sat going off, and I walk by his room and I hear him kind of gurgling and stuff. My patient right now in this setup is just strictly breathing right on his own. All he's doing is getting supplemental oxygen from the wall here. Okay, and my supplemental oxygen right now is set at 50%. All right, so it's dialed on here is what the oxygen is requested by the physician. Okay, the flow is over here on the side. It'll tell me at 50% that I need my liter flow between 8 to 12. So I'll put it at 9 liters. What that will do is it will allow enough humidification coming through here that my patient will get moisture into his trachea and will help thin his secretions out. The other way we thin our secretions out is by giving our patient tube feeding or free water. So we always want to keep track of that intake and output. Okay, the thicker our secretions are, potentially they're developing some kind of an infection in there, or they're not hydrated enough. Okay, so we're going to have a suction cath kit. Go ahead.
What do you mean tube feeding or free water? You just put the water in?
So water is extra water that we're giving them. So if we have a continuous tube feeding, we will be requested to give the patient 120 milliliters of water every 4 hours.
Oh, okay.
So it means in addition to what they're getting from their tube feeding. Yeah. So I've got a number 10 trach here, number 10 suction catheter. If I have a really small trach, I want to have a smaller suction catheter, okay? I don't want to completely occlude the inside diameter of my trach, all right? So I have assessed my patient first. One, I've assessed his breathing, and I have assessed his O2 sats over here, and I've listened to his lungs. And hold on just a second, Jim. I don't have one. This one doesn't have a set of gloves in it. Like, wait a second. It's not one that I want. I want one with a pair of gloves. So that one doesn't have a pair of gloves. So here we go. So I can see that my patient needs to be suctioned. I'm going to open up my kit. At my bedside, I'm going to have one of these suction kits. I'm going to use this little cup here. This is going to have that I can pour my saline into. Okay. A pair of gloves. This kit happens to have 2 gloves in it. Otherwise, you could use just 1 glove. So I'm going to put on my sterile gloves. The other thing I would have done also is I would have turned on my suction over here, because once I put on these really crappy gloves, I'm going to not want to touch anything over there.
And you put them on, what 100, 120?
About 120. We can put them on 120. That's a good amount. So for me, I'm left-handed, so my left-handed is just hand you can see is sterile. This one's not sterile any longer. And I could have, before I touched this, I could have navigated this little pink part out here. I'm going to attach that to my suction. Pull this out. I'm going to check my suction just to make sure I'm going to moisten my tube. Okay. I always widen my tube up so that I can then be able to pull the oxygen off my patient. So I'm going to pull the oxygen off my patient, unwind it. Going to go down. Coughing, apply suction and coming out. I'm going to put the oxygen back on so that the patient can oxygenate. How long do I wait in between?
1 minute.
Okay, it's a really long time.
30 seconds.
Really long time, 20 to 30 seconds. So when you guys practice this, see how long 1 minute is. That patient's got a lot of secretions in there. What we want to do is get them out. Okay, so 20, I know it does. On a 1 minute is a really, really long time. That patient that I've just sucked them out and I want to get them back up again. So I'm going to go down again. Didn't get many secretions that time. Look at my patient. My patient has a bedside monitor. This patient should have a continuous O2 sat on. They're on oxygen, they have a trach, they should have bedside oxygen saturation available there for you to assess. Okay, if I can do this, often what I will do is leave my stethoscope hanging on my neck and I will reassess the lungs. Okay, we can usually go down 2 to 3 times is all we can do. If I have a patient that I'm getting just tons of secretions out, there's where I may take 2 to 3 minutes in between and I will go ahead and resuction my patient again. Okay, giving them a chance to kind of get their sats up a little bit, and then I may go down one more time. Okay, and that's going to be it, guys. We're done. Okay, dungeon.
I have a really important question. Can you suction a TB patient like that?
Yes.
What patient? TB.